Hello and welcome to our True Women's Health Facebook Live. Tonight, we're going to talk about a very timely issue as it's National Diabetes Month. We're going to talk about diabetes and all things blood sugar that are important to know for you, for women, and for your families. A little secret, something that's hitting me really hard is next week is Thanksgiving, which means we are full on into the holidays. And there's never been a better time than to talk about blood sugar and healthy eating and all these different things about our health that are so important than during the holidays. Tonight, I have the pleasure of welcoming a guest, Kristi Paguio. Kristi is a licensed clinical social worker as well as a diabetes care specialist. So she helps patients with diabetes on multiple fronts. And she has extra training in talking with patients about obesity and weight management. Kristi's been in the field of diabetes since 2007. She's worked on a variety of different advocacy groups and speaks on a state and national level in educating patients about the mental and emotional aspects of having diabetes. She's also a faculty at a diabetes training camp and integrated diabetes services and 2 national teams that support people with diabetes. She's very active within this space. And personally, Kristi herself was diagnosed with type 1 diabetes since 2000, and so has her own sort of special take on having diabetes and what that means. Please welcome Dr. Paguio to the show.
Hi, thanks for having me.
Hi. All right. So tonight we're going to talk about diabetes. I know that you like talking about diabetes with patients and sort of the importance of all, the emotional aspect in getting this diagnosis, starting a treatment plan, and kind of understanding what that means.
Yeah, absolutely. And the journey with it, right? Like trying to live or put it in remission, whatever that is, but like living with this condition. So
yeah. And so, just as a reminder to everyone who's watching, if you have a question, please feel free to post a question in the comment section. We'll try to get to everyone's questions, as we're able. So kind of let's get started. So let's just talk about the burden of this problem. There's so many different ways to cut down kind of how big of a deal diabetes is for our country and the world. If we even just look at a quick cost. So right now in the United States, it costs $1 billion a day to treat all of our patients with diabetes, between treating their complications that arise because of diabetes and providing everyone medications to sort of get their blood sugars under control and provide them the appropriate diagnostic materials to sort of check in with where that's at. That's a big boy number, Kristi.
That's huge.
Yeah. One of the other, go ahead.
Yeah, this is so common. This is such a common struggle.
Yeah. And I think it's one of the, arguably one of the more expensive kind of medical problems that we treat, mostly because of the complications that arise, because diabetes really affects kind of every part of our body. And we'll kind of dig into more of that. Another kind of staggering statistic. So from 2001 to 2007, the number of young people under the age of 20 who have a new diagnosis of type 2 diabetes has grown by 95%. Again, a really big boy number. I see a lot more adults than I do, young women under the age of 20, but I definitely can feel that even within, the teens and the young adults, that this is a growing problem, in addition to the adults, which I think is one of the more scarier aspects of this. I know you see a lot more kind of younger kids. Do you feel that presence kind of at these, like the diabetes camps and with the families?
So I actually work with probably a smaller number of kids and more adults, but I would say teens and adults I've got a few children that I work with.
Yeah.
But I think on the bigger front, I think in my private practice, so the groups that I tend to work with diabetes tend to be focused a lot more around type 1.
Yeah.
And then but what I do in my private practice is really working with my clients that are struggling with how to incorporate lifestyle management, modifications, all of that. And then, and really with the whole family. And so when I think about children struggling with weight, it's really most of the time, right? It's a family issue, whether that's the genetic pool or the lifestyle modifications that everybody's kind of struggling with across the country, across the world.
And that's why I love being in women's health, because we know that women make the majority of kind of health decisions for their family, right? Who they're going to see, the food they're going to buy, what's our kind of activity plan. So that's why I love being in women's health, because I really know that I am doing kind of a bit of a downstream effect of helping their kids and families as well.
Yeah.
All right. One more quick statistic to talk about kind of how staggering this is. So currently, as of a 2018 study, only 6.8% of the population of US adults in this country is in optimal cardiometabolic health. So what does that mean? Only about less than 7% of us have a normal weight, normal blood sugars, normal cholesterol levels, and normal blood pressure, just without any sort of medications. Yikes, that seems like a really low number. And I think that it's important that we kind of keep educating people and providing them some guidance on some treatment plans, whether that be lifestyle changes or adding the addition of medications and keeping their emotional health in check.
Mm-hmm.
So let's talk a little bit about what kind of diabetes is and what we're talking about. We're just going to throw a quick slide up here. So when I think about, having diabetes, and we will get into the difference between type 1 and type 2 diabetes, but kind of in a more broader scope, I think about having diabetes, I think that we have a sugar processing problem. So, when we eat, particularly if we're eating carbohydrates, what we're kind of taking up and breaking down is a lot of different molecules, but the one that our body runs off of is a six-ringed carbon molecule called glucose. So that's what our cells want to turn basically those carbons into energy. And that's what our cells need then to fire and to sort of do all the amazing things that they do. But in order to get that glucose into cells, it needs a hormone called insulin. And insulin sort of acts a bit as the key on a cell at an insulin receptor in order to get that glucose or the energy into the cell to be used formally. Obviously, that's kind of the beginning of a very complex process. But in general, that's kind of what we're talking about. And what ends up happening from a clinical point of view is that there's a muck up in this system, right? So there's too much glucose that's staying in the blood and not enough getting into the cell. And a lot of that times that comes because the insulin that is there that was secreted isn't working appropriately at the insulin receptor and can cause a bunch of different issues. As you can see in kind of the healthy picture on the left, that the insulin's locking onto the insulin receptor and kind of allowing the glucose to freely move into the cells as would be normal. And so the cells can get all those appropriate nutrients that they need. And one of the kind of most interesting things is the biggest sink of our glucose or all this energy is our skeletal muscles. They absorb about 80% of the glucose we consume. And of course, that's going to come into play later when we make recommendations about how do we sort of fix these problems. But I think that's a really staggering number and important to remember that how important our skeletal muscles are, not just for strength, not just for balance and fall prevention, but also sort of as they're part of this whole metabolic chain. So we're going to move on next, sort of looking at the differences between kind of type 1 and type 2 diabetes. This is really a talk more about type 2 diabetes and less about type 1, but it's always important just to kind of differentiate because although they kind of have the same name, they're actually two separate completely different processes. So type 1 diabetes, which is the middle picture, basically our pancreas, for a variety of different reasons, isn't able to make any insulin at all. And so even though we have appropriate levels of glucose in the blood, without any insulin, we can't move that glucose into the muscle cell itself. And so the glucose stays high in the blood, causing a bunch of kind of issues and medical problems. Versus when we have type 2 diabetes, we do have enough of that insulin molecule. Some would argue at times too much, and there's a bunch of different theories as to why that is, but there's a problem actually at the functioning of the insulin receptor. Again, that key isn't fitting into the lock, and it's not allowing the glucose to get into the cells. And again, the glucose stays in the blood vessels, sort of causing many different problems. Kristi, I don't know, any thoughts about this? I know you sort of deal with a little bit on the emotional side, but any sort of thoughts about some of this processing or, what patients' thought process between having type 1 and type 2 diabetes?
Yeah, as you were talking, I was thinking, I think very practically, right? Like, I love the overview that you're doing because it is helpful to differentiate type 1 from type 2, even though the treatment for type 2 can mimic what we do in type 1.
Mhm.
I love what you were talking about with how much our bodies use the glucose in our bloodstream for our skeletal muscle, making me think so much about how important movement is.
Mhm.
So not only the mental and emotional side, but even the physical side of our mental and emotional side. So I'm often talking with people about how much we need for coping strategies, for stress management, for all the things that you're going to speak a little bit more about, but like movement, like moving our bodies, moving those muscles, not just for blood glucose, but also an insulin sensitivity, but then also for our stress management.
Yeah, yeah. So I think I really love this picture. I think it is a great sort of overview, and I think you can really tell that when insulin is either lacking or non-functioning in the way that it should, that we tend to have more of a glucose problem in our blood, and that's really what we're the heart of kind of what we're getting at in terms of fixing medical issues. So, how do I know that I have diabetes or any issues with sugar processing? So, we can quickly pull up the next slide and sort of look at the different ways that we diagnose it. And I think it's really funny because we've definitely had a lot of progress in learning our thresholds for doctors wanting to screen for diabetes, right? So you can be at high risk for having diabetes or have some signs of diabetes. And I would say about even 5 to 10 years ago, doctors were sort of hesitant about even screening and looking for diabetes, which I think that's changed a lot. So, kind of what are we talking about? So, there's a lot of different ways that we can measure our ability to handle sugar loads. So, one, you can do a test called the hemoglobin A1C. And what that test is it's looking at the sugars surrounding the red blood cells. And from that, we would get a number. So 6.5%, 5 to 7, below 5, and this is a number that's pretty common now. And once that number sort of crosses a threshold, so we can see the green is below zero point 0.5, I'm sorry, 5.7, the orange is between 5.7 and 6.4, or anything above 6.5, you reach a different category of having a diabetes risk. And so, really, it's just crossing a threshold. There's really nothing more to it than that. Another way of looking at whether or not you have a diagnosis of diabetes is looking at a fasting blood sugar. A lot of the times, this is the sugar that's done first thing in the morning when we're drawing labs. And again, we're really just crossing different thresholds. So if I wake up in the morning and I fasted for, 10, 12 hours and my blood sugar is 99 or less, I would say that that's normal. 100 to 125 is what we would call pre-diabetes, or above 126 or above is actually an official diagnosis of diabetes. The last way that we test someone for having a sugar problem is we actually give them some sugar. And so what ends up happening is that we give them a large, like basically shot of glucose, or we call it dextrose, and we see what their sugar does. So in patients who have a healthy pancreas, healthy enough insulin, and the insulin working at all the cells, we should be able to move that sugar from our GI tract, which has been moved into our blood, into all the cells appropriately. If we're unable to do that, meaning if we test your blood sugar after taking a glucose tolerance test or taking that big shot of sugar and it's still high, then we would say again that you have a diagnosis for having either prediabetes or diabetes. So any one of these treatment models is sort of what's used currently as standard of care to diagnose a patient with diabetes. And I think down the pipeline, there may be more things coming, but this is sort of standard of care for now. I know it can be really nerve wracking for patients, particularly on screening yearly exams, or if they've gained a little weight, to sort of have these tests. I've actually had one patient tell me that they just didn't want to be tested at all because they didn't want someone to tell them that they've had diabetes. And I could totally feel the weight of this diagnosis that they sort of have. But at the same time, it's really important to sort of know these numbers. And even if your primary care doctor isn't thrilled about drawing it for you, I would put a little pressure on them, particularly if you had any sort of risk factors for having diabetes. So that includes, having extra weight that you need to lose, like a diagnosis of having obesity or have been gaining weight, had issues with blood sugar during a pregnancy, have a lot of family members that have diabetes, and a variety of other risk factors that can be really important in putting you at much higher risk for having diabetes. And it'd be important to do any one of these 3 tests. Probably the easiest test is a hemoglobin A1C, which is just one simple blood test, and it doesn't need to be fasting. So, Kristi, I know you see people kind of after they've been given a diagnosis of diabetes, but it can be really a roller coaster to get these diagnoses, to have an official diagnosis, and to kind of flip your mind about where you need to be with your health.
Yeah, I think when I look at this, I think of how much the conversations that I have with people, and I think about, as scary as it can be, sometimes it's relief, sometimes it's scary. Well, oftentimes it's scary, sometimes it can be a relief, but I always think about, to know is better, because then we can really focus on keeping you safer. And so, and there's so many therapies that are out now for weight, for blood sugars. Like, there's so many tools that knowing, I always think about diabetes and how to keep ourselves safe, instead of like what I should be doing or shouldn't be doing. And instead more about how to keep ourselves safe, kind of in that green zone. I like the green, yellow, and red, but really more, how do we keep ourselves as much in the green zone so we're safe?
Yeah. And, it is possible to have one diagnosis or one, let's just say hemoglobin A1C above 6.5, and then to really make some changes and have that number come down. That is totally a possibility.
Absolutely. Yeah,
Yeah.
absolutely.
So Emily asked a question, my maternal grandfather and my uncle, my mom's brother, had diabetes and had died from those complications. And we're sorry to hear that. Is this a risk factor? When we talk about risk factors in terms of family, we're really talking about first degree relatives that we think the most about. So that's mom, dad, or a brother and sister, or your own kids. These are more second and third degree relatives. So we wouldn't consider that to be high risk. And I'd really think about mom and dad and your siblings in terms of your own risk for developing diabetes. All right. So why does having diabetes matter? So we're talking about all these blood sugars, and we realize that it's really important to know kind of where I'm at in terms of my own blood sugar. Why does it matter? So really, diabetes and its complications kind of affect every part of our body. So you got to remember, we have blood vessels that are providing blood and oxygen to every part of our body, from the tips of our toes down to up to our tippy top of our brain. And when there's that extra sugar that's in the blood vessels, and it's causing either vascular issues or nerve issues, it causes a ton of problems. So this is sort of just a poor lady who's obviously been struggling with some diabetes and developing a lot of complications. So some of the big boy things we talk about are kidney disease, heart attacks, and strokes. And then some of the very common but less kind of thought about complications are a lot of issues with our eyes, because the blood vessels in our eyes are very delicate. And when we have extra sugar in our blood, it really can clog up those delicate blood vessels, creating a lot of problems with our eyes' ability to sort of focus light. And peripheral neuropathy, which is a lot of pain in the at like usually the most distal parts of our body. And the teeny tiny blood vessels that supply our toes and our feet can get clogged, and the nerves there can cause a lot of issues, leaving us prone to having kind of big ulcers or sores, or just kind of frequent pain that's there. So I'm sort of speaking more to the medical side of all these complications. Kristi, I know you really see a lot of the more emotional piece of having diabetes.
Well, in this, the slide that you were just showing is a lot of the burden that people feel living with diabetes, or that they're afraid of these complications happening. And so from that psychological perspective, those are the things that I'm talking with them about how the reason why Dr. Egan's of the world, and and the collaboration with someone like myself is really trying to keep them in that safe zone so that they're at less and less risk for some of these complications that with technologies now, we can really reduce the likelihood of some of these happening. The more aggressive and the more proactive we are, we can stay
Yeah.
in the safe zone much longer.
Yeah. And I know specifically, which is really interesting, we'll just touch on briefly, right as women are going through menopause, which is, the time of our, is the reproductive phase where our ovaries stop producing as much estrogen as they did, 5, 10 years ago. It's really interesting. There's a huge bump up in the rates we see of diabetes and weight gain. And it's really interesting that link between our lack of estrogen and our inability of insulin to function and our higher rates of having blood sugars. But that can be so hard for women as they're going through so many other emotional shifts that come with going through menopause, right? Kind of the acknowledgement that, that they're aging and things are happening. Women tend to have more anxiety and they're dealing with lack of sleep because they're maybe having night sweats and hot flashes. Then on top of that, they have to think about, oh my gosh, I have to start thinking about my blood sugar now. And it really can feel very heavy, for lack of a better word.
Mm-hmm. Mm-hmm. Yeah, and I think that the aspects that I would be helping anyone with would be really on like, how do we take care of ourselves? How do we reduce our stress? How do we work on our sleep hygiene and our exercise and our relaxation strategies and all those things to sort of complement aging with diabetes or aging in general, and like it's all so interconnected.
Yeah. So let's talk a little bit about kind of lifestyle changes. I know, in our office, we do a lot of lifestyle stuff. That's one of the main things that we really harp on for people. Where do your thoughts go with lifestyle changes, and what are some of your kind of beginning recommendations?
So I always recommend starting small, like picking one thing, kind of really listening for what someone is contemplating doing, or maybe they've started kind of putting something into action, and then building from that and building up some confidence and maybe some rewards, and focusing on ways that they're noticing changes that aren't necessarily always on a scale. And then thinking about how do we start to add to that a little bit? But the big thing is not getting too overwhelmed or feeling like I have to make all these changes. It's really more about the tiny habits that we start to make that lead to other things as we start to feel more energized and less stress. So it's really trying to look for the stress release part of the lifestyle modification, starting small.
Yeah. We, in our office, we talk about something that we call seeds, which we say are the 7 essential elements of daily success. And sometimes when we're reviewing it with the women patients in our office, it can feel like, oh my goodness, like how am I ever going to do all these things at once? Right. And we always use the comments, I've said to women, don't think about this as like a big finger wag that you have to do all these things right now, as more of a kind of a gentle whisper, right? And what calls to you. So some of the things that we find for women in particular, like no one's drinking any water. And that tends to be one of the first things that we'll lock onto for women. And then maybe exchanging out a sugary beverage for a glass of water, versus having, several cans of regular soda, or that like third chai latte, being like, let's have maybe, a nice cup of tea or a couple of glasses of water first before we kind of immediately lock on to like more of a sugary beverage. And I think one of the other big categories is sleep. So do you feel like you have to talk a lot with your like diabetes campers about sleep, and do you feel like that's a frequent point of conversation?
It comes up all the time in my practice of understanding too, like the relationship when we're sleep deprived, right? Like the goal being trying to get to 7 to 9 hours of sleep each night, right? And that helps with our stress management, that helps with our appetite, our energy level. Because when we don't get enough sleep, we'll often start craving more carbohydrates as an energy source. Our stress levels higher, like our emotional ability is worse. Like, so sleep
and
is.
Kristi, I wish I could say it was always like the good carbohydrates like broccoli, but it's usually not, right?
Mostly it's not.
It's
Exactly.
usually not.
The
Yeah.
processed ones that we tend to crave that pack the most energy. And so it really is yeah, it really is a delicate balance of all things, but we don't have to do all things at once. We can start
Yeah.
making one single change,
Yeah. And
really
it's
keeping
really
our eye on the prize with the 7 seeds. And
it's really interesting because we tend to find, which can, this is a bit of a snowball effect, but we tend to find women who are starting down this journey and maybe aren't sleeping because they're having night sweats.
Mhm.
If we can start with some other changes, right, to kind of help bring their blood sugars down.
Mhm.
And in addition, a lot of times we find that that helps their night sweats,
Mhm.
and then they can sleep better. Then they're able to make a better choice. And it does create a little bit of this snowball effect. And
Yeah.
so you're right in a sense that it can sometimes just start with a few movements forward. Now, can we spend a little bit of time and talk about nutritional kind of recommendations? I will say that I feel like talking about what to eat in terms of food can sometimes feel so overwhelming for people just because there's a lot of noise out there about what is healthy eating. What does that mean? Everyone kind of has their own plan, myself included, that I like love people to eat. But the fact of the matter is, we know there's not one right plan for any one person.
Mhm. When the recommendations I tend to gravitate towards are the healthy plate.
Mm,
So
okay.
from the CDC, I believe, on the healthyplate.gov, I believe,
Mhm.
which is that half your plate is your green. I don't get into a lot of nutrition pieces. I leave that for my colleagues that specialize in nutrition, um, but really trying to keep a balanced plate so that we're not getting into a lot of food rules. Food
Yeah, can
rules
you
tend
explain? Yeah, please explain a little bit more about food rules and sometimes how that can maybe actually veer us off track versus keeping us on track.
So food rules essentially comes from disordered eating, and what we really want to be careful about is that we have a balanced nutrition, balance. Like we're also very connected intuitively with how we feel in our own bodies, and once we start kind of the diet mentality and food rules, and people really, I was just in a store over the weekend listening to someone kind of brag up about all this elimination detoxing that they were doing, and I thought that's okay as long as like it's sustainable, and that you're not falling into too many food rules, and then the disordered eating and the disconnection from our bodies and really trusting and listening to. So the
Mm,
food rules tend to lead to um, over restricting, which
mm,
results in overindulging or binging. And so I like to think about and talk about really listening to our bodies and trusting, and then giving ourselves more permission in a lot of ways,
mhm,
which
mhm,
has the balancing effect of, instead of the pendulum swinging from over restricting to
mhm.
overindulging, we can find ourselves giving ourselves more permission and listening, and paying attention to how does that food actually feel in my body.
Yeah.
So it's befriending these parts of ourselves instead of unfriending or disconnecting from ourselves,
Mm.
actually befriending these pieces of us.
That's so interesting. I feel like one of my favorite questions that I ask back to patients, because a lot of people like will ask me, what my thoughts are about what they should be eating. And I will say one of my favorite questions is I'll say, well, what do you want to eat? And
Mhm,
sometimes people have literally no idea what they would want to eat, like
mhm.
what strikes their fancy,
Because
right?
what tends to happen, right, is like if somebody tells me, like, Kristi, you can't have potato chips, that's all I want. Like, that's
Yeah,
all I'm going to want now, because it brings out kind of the rebelliousness in me
right.
and in all of us. And so that's why we just have to be careful about having too many food rules, and instead more of like, here's kind of my goal. And I think about it like the healthy plate, as a way of, we can mix and match different
Yeah.
things, but that all foods fit.
Yeah, and I know, and I find it really interesting, and I know this is a little outside of kind um, of your scope, but I find a lot of times the different food orders as being a really interesting way in order to provide a little guidance in helping people sort of make food choices. Meaning, sometimes the order of which we eat our food will actually
Mm.
assist with changes in our blood sugars down the line. So, for instance, if I were to have like a heaping bowl of mashed potatoes, for instance, first, right? And then eat all my big salad in my, or not have a salad, or, and just have mashed potatoes and gravy, let's say, for instance, right? Maybe my blood sugar go up higher versus if I had, maybe I'll have some raw veggies as an appetizer, then I'd have a salad and my turkey, which is protein, and then I have my mashed potatoes. Actually, there's a bit of a buffer, right, with the in my blood sugars and some of that other fiber that I was eating and the protein. And I find that stuff really interesting. I think with the advancements of something that we call continuous glucometers, which is kind of a patch that you wear. I know in the type 1 diabetes world, they've been using these for a while to help kind of track blood sugars, but we're using them more frequently in type 2 diabetes. And I'm even a strong recommender for people who have pre-diabetes, even to kind of get a handle on where our blood sugars are at. I know that's not every doctor agrees with that, but that's sort of my personal experience. I find it to be helpful. But I feel like with the advancements as those become more available for patients, that we'll see a lot of different trends, and people will be able to say, you know what, I really was able to enjoy some of the things that I wanted at Thanksgiving, for instance, right? Without having these like hard lines of no, absolutely not at all. You can't have any of those things, if we can learn a little bit more about our bodies and our own responses to food.
Mm-hmm. One of the suggestions that I think about too, especially bringing up the holidays, is I was just talking about this with a client of mine, is that she's working on weight management, and this is her first holiday, really trying to keep momentum going. And so we talked about what she did have control over, and some of that was maybe not going into when, I don't know when dinner was going to be, but not going into Thanksgiving overly hungry. And so thinking about paying attention to her hunger cues so that she didn't set herself up to overindulge because she got too hungry.
Yeah, Kristi, you bring that up. We talk a lot about this in our weight management program. We call it the ping to eat, right?
Mm-hmm.
So it's even just sitting there a little bit with your body of saying, is my body really hungry? Like I'm starving and I need some fuel, or do I just want to eat, right? It's my grandma's pumpkin pie and it's Thanksgiving and that's what I want to have.
Mm-hmm.
Neither answer is a wrong answer, right? But sometimes it can be really helpful to acknowledge that, like, I'm super hungry, maybe on top of being super hungry, acknowledging that, I'm going to see all these amazing foods that I'm going to want to eat, that's maybe not the best combination moving forward, because I may have a tendency to overdo it. So why don't I have breakfast, right? Have a good, get my body some good fuel, and then I'll go to Thanksgiving. Of course, I'm going to be a little bit hungry because I'm going to see some food, smell some food, hear the food. It's going to be like on the tip of my tongue, and I'm going to have some and I'm going to enjoy it, whatever that means for me. But at least I know going in that I'm not going to feel kind of overly hungry and my body's just going to be sort of screaming for fuel.
I talk about this quite a bit too. And one of the things that I think of it more is like when we're truly physically hungry, it is good to pay attention to that. A craving generally tends to be a little bit more of an emotional response. When we're truly hungry, I always like to say, if I'm now hungry, like wallpaper starts to look delicious to me. And so, but if it's a craving where I'm like, I don't know, I think I kind of want
it's
something.
not the right type of pie, right?
Right. And that's probably more of from a more of an emotional, psychological perspective. So that's one way to differentiate hunger, true physical hunger.
Yeah, I've been telling my patients, even as we're headed into the holidays, to even say, what are like 3 things that you're like, I'm definitely having this, right? Kind of things that you maybe would have always shunned at, but be like, no, pick a couple of things and be like, I'm having this, right? I'm having my grandma's cheesecake or that one neighbor's cookies, right? And again, just acknowledge that maybe that's something that for this holiday season that you need, right? And really mindfully eat it, but then kind of be able to move past it, right? Because in January, when it comes, when we're trying to get you to eat your healthy plate with all those vegetables, your brain's like, okay, I had my cookies at Christmas, or I was able to enjoy this experience, which is the holidays, and like I can make a step kind of moving past that. So we talked a lot about how our muscles are a big glucose sink, and how important, what that means then is how important movement is. And I think that's movement on a variety of different capacities, right? So movement's just not sitting. So walking, moving, biking, cleaning your windows, dancing, whatever, to more formalized exercise, right? So either a formal cardiovascular exercise program where you're maybe running or biking and sweating or swimming, or more of like strength training where you're actually lifting weights. And I think any one of those programs is a great place to get started. I agree that people tend to get bogged down in some of the details of exactly what they should do. But I know I definitely tell people that I love them just to pick something just to kind of get started.
Mm-hmm. Yeah, when it comes to exercise, I often think about find something that's fun, and maybe think about it too as a stress management. Like, how can you use it to reduce stress? When I think of stress, I feel like
Totally.
post-pandemic, during and post-pandemic, our stress levels are, I mean, we can just watch the news and like do a pre and post on stress level, right? So
Yeah.
I like to associate, although we all know the health, like we can talk about the health benefits, I always think about the motivator, the long-term motivator is that it feels good. And that it's fun. And so
Yeah.
finding something that you enjoy, and sitting is the new smoking, right? So like anything that we can do to break up sitting, anything long, more than 20
Yeah.
minutes is ideal. And not, I mean, I work virtually, so a lot of times I'm sitting for an hour at a
Mhm.
time.
Mhm.
Um, but really it's trying to break up. So if it's as small as, I mean, back in the day, right, there were like a TV program with a commercial, and that would be your chance to go get,
Right.
do a
Runs
bio
the
break
background.
or something.
Yeah.
Right. And then, but now it's a little bit more challenging with how much we do with technologies and sitting. So,
Yeah.
but any amount of movement has physical and mental and emotional benefits to it. So
Yeah.
we're shooting for 30 to 60 minutes of moderate a day,
Yeah.
but anything counts. So I always think
Yeah.
about, if it's 5-10 minutes, then we'll just do that for a week and build and build and build.
Yeah. And I sometimes think people can put even doing a little bit of strength training kind of on a pedestal. And like, particularly for our moms, we talk about doing a lot of like basic strength training, even with your kids, right? Of doing some squats out in the yard, or lunges, or, push-ups, and kind of having some fun with your kids of adding this in.
Mhm.
Because it can feel daunting to be like, oh, I have to carve out this giant amount of time that I don't have. And it kind of can set us into a shame spiral. So really lowering your expectation of what you can do and really trying to just kind of get moving.
Yeah, and be that encourager to yourself. Give yourself credit for whatever you're doing. You wanna reinforce like that whatever you're doing is better than nothing, even though it
Yeah.
can feel like, I did like before jumping on the call, I was doing some planks and just trying to stretch my muscles and
Yeah.
move my body. And so yeah, just little things, right?
Little
And
things.
giving yourself credit for doing something on a really busy
Yeah.
day.
And even reflecting on the week, if your plan had been to do, 3 exercises or a couple walks and it didn't happen, be totally self-forgiving and review the next week, right? And okay, so after work didn't work, right?
Yeah,
That wasn't part of your plan. Let's try again, right?
right.
And in a completely self-forgiving way.
Yeah, I talk a lot about cultivating self-compassion as a way of helping us get unstuck. So
Yeah.
it's the self-judgment that tends to bog us down and get us stuck. And we
Yeah.
need self-compassion, in particular when we feel like we failed. And so that's a skill, though. We are really good most of the time at giving
Yes.
compassion away, but we don't do it for ourselves. And
Yeah.
so it's the self-compassion that is the mindset shift, like the skill that helps
Yes.
with all of the other things we're talking about.
Yeah, I love that you bring that up. We actually did a whole podcast about self-compassion that if anyone's interested in more information, they could check that out. But I'm sorry, a whole Facebook Live. But I think that women are just so easily can forget to be kind of compassionate to ourselves, right? And we're just the hardest on ourselves.
Yeah, most of us have no idea. Most of the people I talk to have very little idea what I'm talking about.
Yeah.
Yeah.
Um, And, one other interesting thing too, even if you are thinking about your blood sugars, right? You're trying your best to make a good food choice. It can be great to even just take a little baby walk after eating. And that's actually been shown to lower blood sugars, right? So oops, right, it happened. Maybe you had a little bit of extra, pasta or something else than you had planned on, going for a quick walk afterwards and doing some squats right after dinner is, again, our muscles are the biggest glucose sink. So whatever you can do to get that blood sugar kind of up and fired up and moving is kind of a great thing to get started.
Yeah, I love that.
Yeah. Anything else in terms of lifestyle stuff that you think would be helpful before we kind of briefly review some of the medicines?
The only other thing that I talk a lot with people about is focusing on like building your support system. So part of having either one of us in someone's support system, or like friends or other people that you can share some of the things that you're working with or concerned about,
Yeah.
and that you're working on. But really kind of not expecting one person to meet all those needs. And but like, who could you go to when you need more information, right? Like the reason why you're here is to like get more information, but then maybe you need a shoulder to cry on. So like, who's the person that you can turn to that you're like,
Oh, I love that. Yeah.
I just need to vent. I just need somebody. I don't want advice. I don't want information. I don't need like, I don't
Yeah.
want, don't try to fix this. And then maybe you need somebody in your corner that's like really good with motivation. That's like, okay, so will you walk with me? Will you talk with me while I walk? Or will you check in with me about how I'm
Yeah.
doing with making some of this? Or will you partner with me at things, whatever, like thinking about who are some of the different people that you could have. Like if I need help on my computer, like I'm not going to go to the person that, is maybe really good at helping with my diabetes, but I would go to the person that's a little bit more, can offer some tangible strategic support with technical things. So
I think that's so great. Yeah, I totally understand what you're saying.
yeah.
And I do think that it's good to emphasize that everyone has different skill sets. And so
Mhm.
not every person in your life is going to be there to handle that problem in the moment. It's okay to reach out to maybe others.
Yeah,
Yeah.
and I think it's like we build it over time, and
Yeah.
so even though maybe you look at your support system right now and you're like, I don't have enough, but you can, as you start to shift your mind a little bit about, okay, how do I start being intentional about building that support system?
Huh. I love that. I love that idea. We're just going to talk briefly about some of the medications that are out there. So there are so many different medications that are available to help treat type 2 diabetes. I would say usually first line what we get started with for people, and I'm going to pause because I'm going to say this is the current recommendation, and we're going to next move to some exciting things that are headed down the pipeline. But first recommendation to help people with type 2 diabetes is usually the medication metformin. And metformin is kind of a cheap older drug. It works at our liver and our skeletal muscle to get that movement of the insulin receptor in place and kind of functioning better. And people tend to see some actually weight loss with metformin. Not everybody, but a good deal of people. The main side effects tend to be tummy stuff. So some tummy cramping and bloating. But otherwise, it's pretty well tolerated. There's a bunch of different medications in the middle. The medicine that I hear kind of the most feedback that people don't want to take is insulin. So insulin is literally just giving your body more of what it has. And particularly for people with kind of really uncontrolled type 2 diabetes, that seems to be kind of the best way to get those numbers under control. Of course, patients with type 1 diabetes have to take insulin because their body doesn't make any naturally. And I know Kirsty's probably with having type 1 diabetes pretty familiar with having to take insulin, and it can be challenging.
Mm-hmm. Yeah.
Yeah, because not
Absolutely.
only
And it's scary. Yeah, it can be scary, but it is more challenging. But there's so many other therapies out there that we can do, which I know you're gonna probably speak to, but it doesn't, insulin can be scary, but we don't have to jump right to that with type 2.
Yeah,
If we do, it's keeping us in the safe zone. So I always like to think about, it's not a
right.
failure, it's not a death sentence. It is keeping you proactively in the safe zone.
Yeah, and if you're someone that's on insulin, you definitely can make strides and changes to your lifestyle to see that it is maybe possible to get off insulin, and that is possible.
Mhm,
So
mhm.
again, as you said, it's not this like end all be all and death sentence as to what's
Not at
happening.
all, not
Yeah.
at all. Yeah, even if it just makes the progression of it that much less.
Yeah.
Yeah.
So, and I'm just going to touch briefly because I know we've been chatting kind of for a while, but one of the new class of medications that's come out is very exciting. particularly in the diabetes and in the weight loss world. Because I think for one of the first times we're really hitting our stride with finding the right combination of medicines that not only is controlling patients' blood sugars, but is helping them lose weight. Because that was one of the main complaints with insulin is people were gaining a bunch of weight with it, and it can feel very defeating. And so this class of medications, we call them the GLP-1 or the glucagon-like peptide 1 agonist, or they're hitting on that receptor at our brain, our liver, and our muscles, all these different places. And so normally all of us, when we eat, we have this hormone inside our bodies and it leaves our small intestines. And basically, it's our body's signal that we have food there. So it goes to all these different parts of our body to tell our brain and our liver and our fat cells, hey, look, we've got food here. So let's run a little bit more effectively. A couple of names of these drugs, the brand names go by things like called Ozempic or Victoza. More recently, there's this drug called Mounjaro, which is the brand name. The generic name is called tirzepatide. And it's very, very exciting because not only is it really lowering people's hemoglobin A1Cs, but people are losing an astonishing amount of weight. And I was just at the obesity medicine conference about 2 or 3 weeks ago, and this was presented, and everyone was honestly quite excited. And I've heard things like, we never thought we'd get here from this. I mean, people lost upwards of like 25% of their body weight. I mean, that is just unbelievable. So we're really entering a different phase of treatment for type 2 diabetes and obesity. Tirzepatide is not currently available to help people who do not have diabetes lose weight. Although some of us obesity medicine doctors have been using it off-label, and that's a whole separate conversation that you could have with us in the office. But for someone with diabetes, I would fully recommend talking, to your either primary care doctor or somebody, your endocrinologist, about going on this medication because it's really quite exciting.
Yeah, I can't say enough about GLP-1s.
Yeah. And I think one of the most exciting pieces, Kristi, which I'm going to sort of speak from my clinical experience, is people seem to have better control over their eating choices, their food choices, which is one of the most compelling pieces of this, right? That it doesn't feel like this constant struggle for some folks who really have these constant cravings of food. I've had it described as the food noise. It's just constantly kind of buzzing in their head.
Yeah, I think about GLP-1s as like it takes the bricks out of the wagon. So like what you're trying to do and the lifestyle modifications and all these things are really great, but it can feel like, oh my gosh, there's just a million things that I need to do. But with a GLP-1 or Ozempic, it's like it just lightens the load, and it takes that, like you were saying, the food noise, it just quiets it some, and then you're really able to focus more on when are you really hungry versus the snacky craving stuff. It's really empowering.
Yeah. So Lori asked a question. Lori, I hope you don't mind me repeating some aspects of your question. That you've been told you have prediabetes and that I'm on Mounjaro. Thus far, you've lost 26 pounds. There are some side effects, which is totally true. Not everyone can tolerate the side effects, which a lot of it's GI stuff. And do you feel that we should have sugar checked on this? I do think that it can be helpful to have so one, again, I argue that a lot of people should probably be on Mounjaro. And I think over the next 1 to 2 to 3 years, a lot of people will be on Mounjaro, or tirzepatide, depending on insurance coverage and what people can get covered by their insurance plans, which tends to be the biggest barrier currently. I think that's a great idea for you with kind of the little bit that you've told me. 26 pounds is pretty standard for what I've seen thus far in my clinical practice. Having your blood sugar checked. Yes, I think that it's important. That's a really interesting question. I would definitely not do a repeat hemoglobin A1C any sooner than after 3 months. Every 3 months tends to be probably the quickest that hemoglobin A1C would effectively change, and then we would change management. One thing that you could consider would be doing a continuous glucometer with a history of prediabetes, because that can sort of tell you a little bit more information about your day to day. But honestly, most people tend to do well and their blood sugars will get better. And so even if you got it checked in a year, I don't know if that would necessarily change management, particularly if you needed to lose weight and you feel, comfortable and it's medically safe to lose like 26 pounds or more. So Laura, I hope that sort of answered your question. But Kristi, I'd love to hear that you, like, from your aspect too, are okay with the GLP-1s, because, sometimes we get our own spaces and we get excited about it, but it's nice to hear from a completely different clinical practice that you find it to be helpful and effective.
Absolutely. And thinking of like Lori's question, like one of the things I think about that I like so much about is that the risk for low blood sugar is dramatically low. Like there's not as much of a risk, and correct me if I'm wrong, Celia, but like that's one of the other benefits of it. So like overall, it's going to help lower your A1C because of multiple factors, less glucose being released by the liver and less appetite and all of that. But you're not at risk like you would be, because most GLP-1s are an injectable. And so you don't have the risk for low blood sugar unless
Mounjaro in particular, I've seen a little bit more of a lower blood sugar than I would like a Wegovy or a semaglutide, because the Mounjaro actually has a separate hormone too. So in addition to the GLP-1, it's actually a glucose insulotropic peptide, which is really interesting. And one of the most exciting parts about tirzepatide that they looked at is, so anytime we've ever helped someone lose weight, so whether that's bariatric surgery or low calorie diets or any the other weight loss medicines, we've over time seen a really gradual decline of patients' energy expenditure. And for the first time with tirzepatide, when they looked at this medication over 72 weeks or 6 years, they actually saw a retaining of the energy expenditure, which I don't think we 100% know and can explain. So it's really interesting. And I think more information will come out as we start using it more, and we can do some more retrospective studies as to looking at where people are at. Of course, a lot of the strength training folks would say that a lot of the times that's because people weren't doing as strong of strength training programs and being able to maintain their muscle mass. But it's kind of an interesting conversation and very, very exciting nonetheless.
That's what I was thinking is like with the statistics that you started this conversation with, like, this is what's so powerful about the medications that are on the market, that it doesn't just have to be quote unquote willpower, but there's medications and therapies to help with this disease.
Yeah. I know, Kristi, that I always say, no one ever comes to my office and is like, oh, Dr. Egan, I shouldn't have cookies. Thank God I came in, right? Mm-hmm. Like it's all about, I know I shouldn't have cookies. I would love to have one. Should I have none? Should I have 1,000? Should I just give up? Like, what direction am I going in? And I love this medicine because it really does kind of help people keep in line. And I don't know, it's really interesting. And one of the other things that I've noticed clinically is people really talk about not wanting to have any alcohol. So in particular, I have a lot of people that struggled kind of turning down that glass of wine at night, and that taste kind of goes away. And I think that speaks a lot to the reward pathways that are in our brain and the interactions between glucose and alcohol in our liver. And so it's very, very interesting, and time will tell.
It is. What I love so much about the GLP-1s is the psychological side of like, so what am I doing if I'm not going with the food noise in my mind? Like, what am I doing instead? If I'm not as often. And so it's it's a very empowering medication to consider.
Yeah. Okay, great. So let's take some, we're going to do some quick take-home tips, and Kristi, feel free to jump in if anything you feel like a point. So take-home tip number 1, know the status of your sugar processing, right? You should, if you're interested or if you think you're high risk, or honestly, most of all of us, right, should know, do I have diabetes or do I have prediabetes? And so it's really important to talk to your primary care doctor about kind of where you're at in terms of your sugar processing. Number 2, knows your phase of ovarian function. So we hit on this a little bit, right? As women are going through that perimenopausal and menopausal phases of life, right? They're at higher risk for developing prediabetes, diabetes, and all sort of the complications. So in order to kind of know where you're at in terms of your risk, it's really important to know your phase of ovarian function. All right, tip number 3. Are you a candidate for a CGM? So again, a CGM is a continuous glucometer. It can be helpful for definitely with patients with type 1. It's almost a necessity. For patients with type 2 diabetes, it can be really helpful to sort of understand your different interactions with food and help you make better food choices depending on your body and recommendations. There's a strong argument that they can be helpful for other things, like particularly hot flashes. And I know that's what we're doing with True Women's Health and Curia, is kind of understanding the role of CGMs. And so, it's worth at least a conversation with your primary care doctor if that would make sense for you. All right, number 4. Lifestyle changes matter. So it can feel so daunting, right? To be like, oh my gosh, I have to change so much in my life. But we know that people can do it, and we know that it helps and it works. And so I think Kristi sort of nailed on the head is just to kind of start small and practice a lot of self-compassion along the way. Mm-hmm. And acknowledge that I don't think any of us are going to be perfect. If education mattered, I should never have anything that was ever bad for me. But here I am, and I do, because I'm human.
The problem with perfectionism.
That's right. All right, number 5. Okay, learn about the new medicines for sugar, diabetes, and weight management. So we've kind of spent a little bit of time talking about them and how excited we are about this new class of medications called the GLP-1s, particularly this new medicine called Mounjaro or tirzepatide. And it's really important to sort of know what your options are out there. All right, so if you're not from Michigan, we can quickly just review what you should ask your primary care doctor. Number 1, what are my risk factors for developing diabetes? So again, remember if you have any issues with sugar in your family, so your first degree family members have issues with blood sugar, or if you've had issues with blood sugar during your pregnancy, called gestational diabetes, you're at risk for developing diabetes, or if you have a history of obesity, a medical condition called obesity, or you've been gaining weight, or for some reason you've had a lifestyle shift where you're now physically inactive, that would put you at high risk for developing diabetes. And it's always good to review those factors with your primary care doctor. All right, number 2, am I a candidate for diabetes testing? Again, review your risk factors with your primary care doctor, and then you guys can have a conversation about which type of testing for diabetes makes sense to you. Again, our kind of standard is the hemoglobin A1C, but even just doing a fasting blood sugar could be really helpful to kind of see where you're at. Number 3, what is my phase of ovarian function? Kristi may not know, but Dr. Bittner and I are sort of on a quest to make sure that all doctors know what their women patients' phase of ovarian function is. So we want all women to kind of demand that out of their primary care doctors. So, for all women out there, right, know your own phase of ovarian function. If you're not sure, have that conversation with your primary care doctor. Number 4, what lifestyle resources do you have in your area? So maybe there's someone like a Kristi in your area to sort of walk you through some of these lifestyle changes. Maybe there's some other exercise programs in your area. There's a lot of resources out there nationwide that can be really helpful. I don't know, Kristi, do you have any kind of nationwide resources? I know I'm putting you on the spot, but that you kind of think of off the top of your head.
All right. The things I always think about are what are some apps? There's the Peloton app, there's the Nike app. If you're looking for really convenient things, I mean, locally, if you're looking for exercise things, then you could look locally in your area. But I love apps you can take them anywhere.
I think that's a great idea. Yeah, on vacation, on business trips, all that jazz.
Yeah.
All right, and number 5. Am I a candidate for weight loss medications to help with my blood sugar? So most patients, either if you have diabetes, you're definitely, so type 2 diabetes, meaning you met any of that criteria, which we initially showed on the slide, you would be a candidate for some of these medications. If you have a BMI above 30, all flat out, or if your BMI is 27 with something like prediabetes, you'd be a candidate for these medications. My prediction is over time, we're actually going to lower those thresholds because there's no reason why we should just wait for people to kind of gain more weight or for them to develop diabetes before we're like, okay, let's now start the medication, right? I think over time that those things actually will those thresholds will really fall. And, if you're interested in this kind of stuff, please keep your ears out. Well, Kristi, we've already talked for almost an hour now. Where can we find you if we want to talk to you some more?
Yeah, well, there's my website. So please feel free to reach out to me there. You can email me, Kristi at bravingdiabetes.com, I believe is the website, or the email address. Yeah, bravingdiabetes.com. Yeah. And then it's all in there. So
Awesome. Well, I always love talking to you, and I'm sure your patients love talking to you. So thanks for coming on. And if anyone wants to come visit us in the office, I'm available in Grand Rapids, Michigan at True Women's Health, and you can find us at truewomenshealth.com. We have a couple of different programs, but particularly we have a program called our True Weight Journey, where we help women sort of get refocused on themselves and get them on the right weight journey, whatever that may be for them. So please check us out if you're in Grand Rapids, Michigan. Kristi, thanks again. Great conversation.
Thank you. And just so everybody knows, you don't have to be in Grand Rapids to work with me. I work.
Oh yeah, Kristi's more nationwide. I apologize.
No,
Yeah.
no, that's okay. Yeah.
Yeah. All right. Thanks again, Kristi. Everyone have a great night. Happy Thanksgiving.
Thanks.
Yeah. Bye.